Welcome to the NeoFOCUS-UK Education Group webinar series.
Okay, all. Thanks very much for joining this NeoFOCUS webinar. And we're really lucky today. I'll introduce, we've got Professor Yogen Singh, who's come, and it's early in the morning for him, so we're very thankful for him joining us at 7 a.m. He's a full professor of Paediatrics at the University of California and UC Davis Children's Hospital. And we're very lucky because he is the founder and chair of the ISNIC POCUS working group, as well as being an expert in hemodynamics and functional echocardiography. I think one of the great things about today is that he has published not only very widely, but some of the international evidence-based POCUS guidelines for the use of ultrasound in neonatal and pediatric intensive care. So we're very lucky to have his expertise and him presenting today on the targeted use of POCUS in evaluating the crashing infant in the NICU. So without further ado, Yogen, I'll hand over to yourself if that's okay. And we can start whenever you're ready. I can see that we're nicely filling up with lots of people here joining us on the webinar.
That sounds great. Thank you so much, Liam, for the kind introduction. Good morning, good afternoon, good evening, everyone. So first of all, for the NeoFOCUS Education Committee, thank you so much for the invitation. I'm delighted to be here. And as Liam said, today we discuss this really important topic on how to use the ultrasound in a crashing infant and how to make it targeted use for the emergency so that we can get the diagnosis faster. So we call it like playing safe in the NICU, a safer protocol we'll discuss, but we'll go beyond the safer protocol during my talk. So I had no relevant conflict of interest. Two acknowledgements are there. One is I'm executive medical advisor and shareholder for the virtual echo training, what we own. So that's the simulator what we use. And also we did some work with the 1-2 sonography, but I had no financial interest in that one. But that's a POCUS resource which they use for the adults and say a paid course as well. Next 45 minutes. Now, during this talk, I got 3 learning objectives for the audience. One, how to learn the importance of the using the POCUS in the neonatal emergencies. Second, to learn a predefined stepwise ultrasound approach to rapidly identify common causes in a suddenly decompensated infant or collapsing infant. Thirdly, to learn how to use targeted POCUS for the rapid assessment of shock and how to institute a targeted specific intervention timely. So most of you know ultrasound is evolving very fast in the clinical practice. This image, if you look, this is less than 100 years back. It's 1946. Ultrasound was when introduced in the science, in the medicine. And it used to be very big machine it's a big lab, and patient had to go there, and you can see the size of the room, size of the ultrasound machine here. Our OB colleagues were the first one to adopt, and they adopted quite early in 1950s, and very soon it became popular rightly because it can provide the information on the bedside. Gradually became smaller, but still remained in the mostly in the hands of the radiologist, or for the echocardiography in the hands of the cardiologist. And those machines were still expensive, not easily available, and they were big. But with time, those machines are getting smaller and smaller, as you can see in the screen. From the left-hand side towards the right, they're getting smaller and smaller. Now with ultrasound machines, which are ultra portable. In the adults, you can see they are even wireless. They don't need a cord. For the babies, given we still are using high frequency probes, smaller probes, wireless are not that great for the high frequencies, but with the handheld, with the phone or with the tablet, they are getting smaller and smaller and very user-friendly. What I would like to see one day, that you get the stethoscope with a nice screen and just put on the listen to the baby and just say, oh, this heart function look really crappy, they're very bad, and these are good cardiac functions. Some kind of functional assessment with the AI read just as soon as we listen. And I think that will happen. It's not far, but just a matter of time. Why this is, when the machines are so important, why we should adopt? It's non-invasive, we know that. It's easily available, it's portable, and it's bedside. We can do serial evaluations. It's visual, it's powerful, it's people believe in that one once you see what's happening inside the body. And typically, why will you work in dark when you can see inside the body, when you can see the information visually? So it empowers us. It empowers us, the clinicians, to in providing the anatomical, physiological, and the hemodynamic information in real time on the bedside. And especially what I'm passionate about, that in the time critical emergencies or collapsing infants, it saves lives. It can help in early recognition of life-threatening conditions, emergencies, and it can help in targeting early intervention. That's where I see maximum use the POCUS. Rest, our colleagues are there, radiologists are there, cardiologists are there, PECS colleagues are there, other neonatologists are there, who can use more advanced or more detailed assessment of the ultrasound, echocardiography, whatever the names we use. But for the targeted POCUS, where the life-threatening emergencies are there, it saves lives. It can help in choosing the right intervention for the right patient at the right time. There are various protocols have been published in adults and children, and most of you know those protocols. There are various protocols very standardized in the even in the shock patients, even the sudden collapse patient, even during the resuscitation, although they are not routinely used in the resuscitation. So in the adults, you got the false protocol, then you got the rush protocol. Similarly, you got the fast protocol for the trauma patients, and same have been extrapolated into the children as well, like E-fast protocol, E-rush protocol, P-rush protocol. And these protocols are for the targeted use of ultrasound in adults and children. But there was nothing specific for the neonates until recently. Why these are important? Why these protocols are important? If you give too much fluid or too little fluid in emergency to the sick patients, when you do not know the myocardial functions, you may do harm, and there may be poor outcome. If there's a persistent hypertension, we know it's not good. It's definitely associated with the poor outcomes and the neurodevelopmental poor outcomes, and also there's a higher mortality. This late diagnosis is mostly because lack of understanding the pathophysiology in emergency situations, because those are the sick patients you want to do intervene, is getting the lines, providing the airway, and all those management what we do in emergency. And you are not thinking a lot on the pathophysiology broadly there with the fine details, what's happening with the hemodynamics. That is often not accurate. That leads to the delay in the targeted specific interventions, and that all is related associated with the poor outcomes. And from the surviving sepsis guidelines, both in the adults and children, we know all these, what I'm saying clearly, that too much fluid, too little fluid, hypertension, or late diagnosis will lead to the poor outcomes. And we also know that early recognition and timely targeted specific intervention, they can improve the outcomes, and they do improve the outcomes. Just ask yourself for a few seconds. We all do the NLS scores or APLS or PAL scores, and we all talk about the 4H and 4Ts, and typically tamponade, tension pneumothorax, hypovolemia. How many of you clinically diagnose these conditions in the emergency situations? It's really hard. Despite decades of experience, it's really hard because these conditions can be diagnosed accurately, clinically very fast. You may diagnose them, you may suspect them, but not all of them. Similarly, cardiac contractility is impossible to diagnose clinically, and I'll show you why this is so important. Let's take two studies here, two case studies to through this case. This baby is born at 36 weeks by emergency cesarean section. There's a history of fetal tachycardia up to 215 beats per minute. The suboptimal fetal monitoring on the CTZ. There's a loss of fetal movements. Baby was born in poor condition, required coding resuscitation. And team did a great job. I'm not going to a lot of those details. The team did a fantastic job in a district general hospital. And they stabilized and they started the management on the lines of the hypoxic ischemic encephalopathy. Started therapeutic hypothermia protocol. Now, cord blood gases are very poor, including the first blood gas done soon afterwards. Then get the IV line is very poor as well. They're showing the severe metabolic acidosis, pH was 6.8, high base excess -19, unrecordably high lactate. Team did a great job with the examination as well, and they saw the baby looks very pale. Peripheral pulses were weak, and capillary refill time was 3 to 4 seconds. The blood pressure was somewhere around in mid-30s to diastolic was low in the teens. Mean was reading around 17, 18, but that's a non-invasive. Baby still about half an hour old, and the team is trying to get the lines, arterial line. So what will you do next? Ask yourself again, will you give fluid bolus 10 mils per kg? And what fluid you'll give if you want to choose? We'll give fluid bolus 20 mils per kg, starts inotropes, give some sodium bicarbonate because of the severe metabolic acidosis in a decompensated infant, accept the low blood pressure saying, oh, it's only half an hour old and it's only non-invasive. But often there's preterm babies, sometimes we accept the lower side, they'll get better. What will you do? I'm sure all of you intervene somewhere between first to fourth, and most of you choose first one here. Accepting low blood pressure is not the solution here because this baby is clinically decompensated, looks pale, refill time is more than 3 to 4 seconds, weak pulses. So that's not the option here. And so most of will give the 10 mils per kg fluid bolus, and that's what the team did. As they give the fluid bolus, baby had sudden acute deterioration, and again, baby required chest compressions briefly. Question is not about you choose. Question is, how did you make that decision about the choosing your intervention? What do you choose? 10 mils per kg, 20, or whatever you choose up from the previous options. I did ask you a question, and you made from those choices based on your experience or the guidelines, what your unit or national guidelines people have published, or based on some assumption that they will be hypovolemia. We did not consider what's happening with the preload, what this hypoxia or this poor acidosis is doing to the contractility. Is the contractility very poor? What's happening with the afterload? So there's no consideration of the preload, afterload contractility. We just reflexively chose 10 mils per kg. There's no consideration of the compensated mechanisms, what body try to bring in with the underlying pathophysiology. Now, same patients after 3-4 hours come to the tertiary NICU, and this is not the greatest image, but it's a very educational image. Now, this image is, as you all can see, apical 4-chamber, little tilted, but it does the job. Now, we have got the ventricles at the bottom who don't do ultrasound echoes, left ventricle, left atrium, right ventricle, right atrium. Now, if I show this image to the medical students or even the school students, everybody will say, no, this heart is not happy heart. It's a poor contractility. Nobody will say this baby is a hypovolemia. This baby is has a well-filled heart. So preload is not a problem here. Contractility is the problem. This baby is already being cooled. So that will lead to the increased systemic vascular resistance. That will be a problem too. And also may lead to increased pulmonary vascular resistance from the hypothermia and hypoxia and acidosis. So they're very likely this with the high PVR, high SVR. Now, if you do not do this simple ultrasound image or echocardiography, whatever you want to, what your expertise are, You can choose an inotrope what commonly people have been using for the last couple decades. Typically, people choose dopamine, and that's what the team had done for this patient as well. But what that will do, that will increase your systemic vascular resistance, and the LV is already poor contractility, poor functions. That's not going to help this baby. Similarly, RV functions are poor. Higher dose of the dopamine may increase your pulmonary vascular resistance. Again, that's not a really good option. So just by simple image, even not without going the full hemodynamic evaluation on the targeted echocardiography or full echo, just by simple apical 4 image can give some insight. You cannot tell on this image what the cardiac output is, what the LV and RV cardiac output, but you get enough information to choose, let me not give the fluid therapy here. Let me choose an inotrope which can improve the contractility and which does not increase your systemic and pulmonary vascular resistance. So see, that's why if you use the ultrasound in the clinical context, in that case, you can make make this understanding the pathophysiology much better than what we can do clinically or the routine assessment, because that information cannot be acquired on the bedside without the use of the ultrasound. That's impossible. Let's look on the second case. This is a preterm baby who was born around 26 weeks plus and had done very well, was initially intubated, surfactant given, then was extubated. But then, as typically some of these babies can do sometime after a few days, baby had desets and readies, and then sudden decomposition happened. Nurses called and team arrived and they on the bedside, and they did perfect job. They started the coding, started chest compressions, and the two fantastic neonatologists were there, and they did great job. Team did good job as like NLS followed the protocol, and they threw everything in this baby, as you can see on the screen. 3 doses of epinephrine or adrenaline, what you call it, really. 1 bolus of saline, 0.9% saline as well. One fraction of sodium bicarbonate, and O negative blood. You can see whatever they could throw in this baby, they did everything. 15 minutes went by and the good quality coding going on, but there was still babies not buzzing. Still, there's no heart rate or very poor heart rate. Sometimes you can hear something, but not really. There's a cardiac, just the activity or the heartbeat, real heartbeat. And sets were in the low 20s to 40s, sometimes come up and go even during the chest compressions. So this baby is not responding. Just ask yourself again, will you continue the CPR chest compressions or will you stop? And you continue, then how long will continue for? Again, with the NLS, NPS, or NRP guidelines, we say 20 minutes of the good quality resuscitation. Here you have thrown already everything. This baby was, team were there when baby deteriorated, and we have thrown everything. And if you want to continue, while doing the chest compressions, will you ask someone for more help, and who will ask? If you call a cardiologist, even when they're 24/7 in-house cardiologist, they may take 20-30 minutes. You call a radiologist, that may take even longer. So calling from someone is not going to help here because this is a coding situation where the chest compressions are going on. So at that point, I was on call and I was coming to the call, and team called and just I went in, and there we did ask the team, and team said long line is good position, but we had not done the X-ray during the coding. It was again we're waiting for the X-ray. Again, X-ray sometimes takes a long time, including my institution here. Sometimes they can come in 2 minutes sometime, like literally 2 days back with a sudden deteriorating baby, and they came even before I was pulling the ultrasound machine. On the other hand, sometimes they take 20-30 minutes as well. So we pulled the echo machine, ultrasound machine, that was around 15-16 minutes, and then this is the image around 20 minutes. Now, this is the subcostal view. Again, this one you can already, most of you know, is a cardiac tamponade, as this slide shows. But this is a massive cardiac tamponade here. This is the right atrium, right ventricle, completely collapsed, and there's absolutely no the cardiac output. There'll be no cardiac output because the RV is completely empty. If no blood can go in the RV, there'll be no blood going to the lungs, no oxygenation, nothing in the LV, and this baby is not going to respond. So we ultrasound guided pericardiocentesis performed, and you can see the needle coming here. We aspirate it, and this baby gets better, and this baby has got now filling is coming the RA, and that's good. RV and LV is getting better, and this baby responded. So this will be the excellent outcome, and this baby were discharged home. Question really arise from this situation: should the POCUS be part of the resuscitation protocols, part of the NLS NRP protocols? I know we are not there yet because we have no resources. We don't have enough trained people who can provide 24/7, because NRP NLS is provided by midwives, by nurses, by even other people across the world. So definitely we are not there yet. But that raised the question, when expertise are there, should we be using the ultrasound for the collapsing infants? The current dilemma is shall we continue to work in dark and the clinical decision making based upon our indirect cardiovascular monitoring, which are the proxy parameters? Or shall we make a physiology-based clinical decisions guided by the ultrasound, guided the POCUS, guided by the echocardiography? What expertise you have got? So shall we embrace the POCUS in the clinical practice? Shall we accept and adopt? I know you all are convert, that's why you're here, but it's beyond us. We need to train maximum providers, maximum physicians, or nurse practitioners who can learn the at least emergency use of the POCUS. I know people are going beyond and beyond with the POCUS, but you look at the adult world, they have been using only for few indications. And that's where the key is: can we teach everybody first some minimum basic POCUS? And then you got the more advanced POCUS, then we got the more hemodynamic training. We have got the target neonate echocardiography, NP or TNE, whatever where we are. And then with the full echocardiography, the steps are there. I'm talking the very basic steps of the minimum use of POCUS for the time critical emergencies to make a rapid right diagnosis and provide an immediate specific targeted intervention. So we have been working for last few years to develop these protocols for these collapsing infants, and two protocols are available around here. So one is SAFER protocol, which with Nadia Youssef and Daniel DeLuca, we published a few years back in 21. That's a very simple rule in and rule out approach, what I will discuss. Second, we made an international group of experts, right, from the Canada, North America to Australia. And so all people from all over around the world, we joined hands and we made this protocol, crashing neonatal protocol, which is a little more look into the more physiology. For the emergency situation, SAFER is very, very fast, very easy to use, but both are really good protocols. So let's talk about briefly about the SAFER protocol in the NICU. As it is for the crashing infant, it's not for the coding during the chest compressions. A simple one to use is for rule in, rule out. It's just we use this one using the standardized ultrasound points to rule in and rule out. And this protocol, if you look on the other ones, some protocols are based upon the head to end, head to toe, or from abdomen to chest or chest to abdomen. But in this protocol, what we have done really is more, these targeted points are in order of the urgency or priority, where you can revert the situation, where you can find a reversible cause and make this patient better. So there are 6 steps of this protocol. Even before the 6 steps, 1 step comes really, which you look at the contact rate in the hypovolemia. The key point, if you use this protocol, as I said, these are not during the resuscitation. If you use during the resuscitation, it should be used by the most experienced person, and it must not interfere with the chest compressions or the CPR, because we do not want to delay those episodes. Even with the babies in the chest compressions, what I showed you, we never delayed the chest compressions. Team continued to the chest compressions, and we diagnosed tamponade subcostally, and we intervened while they continued the chest compressions. So that was not affected at all. And second point we already said, really, it should be a rapid assessment. It's not the time to teach and train, it's the time to just rapid diagnosis, intervene, and no clip should take more than a few seconds really to diagnose here. So what are the steps? So first one, the rapid assessment of contractility of filling. So that's the step 0, I call it. This is looking at the good or bad. We are not saying mild hypovolemia, moderate. We are not fluffing around. We are saying, heart is empty or full? Contractility is good or bad? Like this slide showing the contractility good on this image on the left-hand side. On the right side here is the bad contractility. So you will not give fluid bolus to this baby, but you can safely give to this baby need to. If you do in this one, it will be no harm. Although this baby is well-filled heart, you will not need. But obviously, it's not a hypovolemia. It's a good contractility. It's a bad contractility. It's a bad contractility. I always say ask for someone who can do TN echo, NP, or full echo, because there will be some other cause leading to this really poor functions. It may be cardiac cause, it may be non-cardiac, but something can be more sinister here. Then we can look on the second, look on the hypovolemia. This is a parasternal long axis view. You can see the right ventricle, interventricle septum, left ventricle. This is the kissing sum of the left ventricle on the right image. So left image, you should know hypovolemia is a normal heart. On the right side is a hypovolemia, classical severe hypovolemia. This has got very good contractility, but hypovolemia will need urgent fluid therapy, more than 10 mils per kg, in this case, 20-30 mils per kg. Once you know contractility is good or bad, whether you need to give the fluid bolus or not, then you want to see are there any reversible causes, such as like tamponade. That's step 1. In this step 1, we start with the subcostal view and putting marker 3 o'clock, just look up. In this case, that's a normal. There's no pericardial effusion, and here you can see the tamponade, what we already saw. If you say this one, there's no fluffing around, whether they've done the tamponade aspiration before or not. If somebody is available who has done before, that's great. Otherwise, you need to intervene this baby, otherwise this baby is going to die. So this is a very time critical interventions, ultrasound guided, is very safe. If there's no tamponade, we go to step 2, we rule in and rule out. In this case, we go look for the tension pneumothorax. We move the probe anteriorly, both the right and left side. In this case, you see the lung sliding, see the B lines, rule out the pneumothorax. On the left-hand side, there's no lung sliding, tons of A lines, not a single B line. Even you cannot see the heart here, you know it's in pneumothorax. The baby is decompensated, it needed aspiration. So this baby is a cancer pneumothorax, and you can need intervention urgently, just like the tamponade. So again, rule in, rule out for step 2. If there's no tamponade, there's no tension in pneumothorax, then you move looking for the fluids, which may lead to a problem in the other organs, typically maybe loss, pleural effusion. Again, that can be from your lung lines, can be from the hydrops patients. They can be different causes. Right. Then you look for the fluid. In this case, you can see the collapsed lung, like a classical squid sign here, a lot of pleural effusion. There'll be some spine sign here. Again, if this large one, you're not able to inflate the lungs, baby is decompensated. In that case, you can aspirate. Baby stable, that can be, we can ultrasound guide the latest, really diagnosing urgent one. Then fourth one is looking on the more reversible cause. Again, POCUS is not designed and is not recommended to use the diagnose or the rule out the critical congenital heart disease at all. POCUS is very limited training, limited indications, but one thing can be helpful, especially in situations where the echocardiogram is 50 miles away. Looking on the, just like the subcostal, be very easy to do. Subcostal marker 12 o'clock, look on the left-hand side, and you see very easy to see the aorta here. That's the vertebral body. Can you see the blood going pulsatile or not? You can pulse your Doppler as well. Again, emphasizing POCUS is not for the diagnostic critical CSDs, and it's not even we see the pulsatility, does not mean that they cannot be underlying congenital heart disease. It can be still there, can be still coarctation, can be still there. But if we do not see any pulsatilities, in that case, heart function is really very poor, or there is absolutely no critical coarctation, and you can call help early, and in the meantime, you can start prostaglandins. So you can help in detection of this poor flow to the body, and also calling for the urgent help. So that wants urgent echo, urgent help, really, that can help. Next one is looking on the other organs, looking on the ascites. Rarely cause a significant problem, but in a baby with sudden perforation, already baby also have very limited reserves. Diaphragm may be pushed and may lead to problems, and sometimes need urgent paracentesis as well. But that you can diagnose, make the clinical decisions, but it help in diagnosing, picking up. And similarly, sometimes other, like baby is not passing it into 6-8 hours, is a massive bladder. Those can you look as well, but this is for the ascites here. Lastly, step 6 is the ruling in, ruling out of the large intraventricular hemorrhage. Again, we're not looking at the tiny grade 1 general matrix hemorrhage. If baby is collapsed suddenly, is large IVs there? Yes or no? Can you do anything about it? May not be like the tamponade, but it can help making the right decision. It's a midline shift, a large massive bleed. What shall we do in these situations? It can help in talking to the parents, talking to your staff, colleague, giving the what shall we do in this time critical, is this serious situations as well. So that's how we can use the safer protocol or the CNP protocols in practice. And there are recommendations are there, as Liam said in the beginning. We have published our guidelines, which are the international evidence-based guidelines for the POCUS use in neonates and children. And they are well accepted all over the world, and they are given some ground for the people to adopt in their clinical practice. And same with the American Academy of Pediatrics, AAP came with the clinical report. They're not guidelines. We're working with the guidelines. Hopefully, there'll come some practice guidelines from the North America as well. But they'll be coming soon. They're being just accepted, really. So, but these guidelines point each other that two big societies, both European, which is very clinically very heavy, and we got ethnic presence in many countries across the globe. Those big societies, both ESPNIC and the AAP, both recommend that POCUS should be used for the emergency situations. And we clearly said that it improves the outcomes. It should be used for the emergency situations. But also equally, we highlighted that it should be used within the scope of the POCUS. Do not ask too much. As I said, POCUS with limited training. I know part of the NeoFOCUS, many people are there who are well trained in the echocardiography. Many people are there who are the POCUS, but there's a big difference. NP guidelines, TNE guidelines, those trainings take 12 months. Those take 250 echoes. This is a long time. It's a imaging, acquiring the images, interpretation, and then using them in the clinical context. That takes time. Hemodynamic evaluation takes time. But POCUS can be easily fast learned, and that's what this society is talking about here. So that's the classical difference when I say it's really important to understand if you're using POCUS, what your abilities are, where your training is. Full echo done by cardiologists or fully trained like PECS people, or then you get the NP or TNE, where it's a protocol driven and protocol based approach really, and it's a long training, 12 months training, competency based as well. But key point at the end really, by the TNP, it can be used to say, is the heart looking normal? Is it looking abnormal? Key is not to diagnose delineate the anatomy in the heart problems, but just saying it's normal, abnormal. And as I said, this is a standardized training programs, which takes a longer time. Cardiac POCUS is very clinical, goal-oriented. Its aim is to gain specific information, target specific intervention, as we showed in the SIPR protocol. Are the contact clarity good or bad? We are not objectively looking really. How is the pericardial effusion? Yes or no? Tension pneumothorax? Yes or no? It's a very specific questions, and you can use to answer those questions using the POCUS in those situations. So that may lead to my second thought. Should the lack of the resource in the staff training be reasons for not adopting this in the major clinical practice? Again, in the UK, in many parts of Europe, we are very lucky. It's already like NPU is well adopted across most of the units, and also PACS are absolutely fantastic resource in the UK, who are available in almost all hospitals, not 24/7. Again, there are only 1 or 2 PACS in every hospital, but when they are there, use the resources both for the clinical management and also for the training purposes as well. So how do I do in practice? Really, I definitely use those protocols in the crashing infants, and equally when baby is decompensated, even during the coding, but use in those situations cautiously, as I said, very rapidly. So baby is acutely decompensated. Still, ultrasound use will not replace the other monitoring or the clinical evaluation. They are the key. We need to know the history. We need the clinical examination or other monitoring. What's happening? They'll give some good idea. Still, those babies are suddenly crashing. You need to go for the same ABC approach, DOPE protocol, DOPE guidance as well. Is the tube still there? Is dislodged, obstructed? All those things you can look where the central line is, because those are the common problems for us in the NICU. Central line migrations or complications lead to the sudden deterioration there as well, either tube or central lines, common problems. Then we can use the safer protocol. In this case, we can use the very targeted ultrasound use to rule out those serious emergencies or diagnose and intervene, target specific intervention. But equally, this is really important. If we do not find them, it helps you get the negative screening, which is not a bad sign. You have ruled out the really time-critical emergency. Now look for the other problems. Other problems can be sepsis, common, critical congestive heart disease, metabolic, and those when you can ask for the urgent help. So even if there's a negative screening, it can help you in asking for urgent help and making the right decision. So to summarize, take-home messages, targeted POCUS is excellent screening tool. It can be diagnostic, can be therapeutic, and can be procedural. But it's an excellent screening tool, especially when you use those protocols very fast, like SAFER protocol or the CNP protocols. And this is an excellent tool for those detecting the complications or the underlying cause. SAFER is a rapidly rule in, rule out for the common causes of the decompensation. POCUS helps in providing the early targeted specific intervention and making the practice safer. Use of POCUS must not interfere with the resistant protocol. If you're using in a baby who's undergoing under chest compressions, then it must not interfere with those standard, because otherwise that will have poor outcome. Know your limitations. Know the limitations of the POCUS, your clinical and training as well. It's not a screen tool for the critical CSDs or a full radiological assessment. It's not an NP, and there's no shortcut for the NP or TNE hemodynamics training. That's take much longer. The POCUS cannot be used for the comprehensive hemodynamic evaluation as well. Those are limitations. Again, I finished my talk by this quotation, which comes from our book. Seeing is believing. If you use POCUS, it looks powerful. You will believe, your colleagues will believe. But you need to see what you look in the screen. Your eyes will see only what your brain knows. For that, when you need good knowledge, good experience, and then imaging will work. Otherwise, if you're basic, you miss the basics, then ultrasound is not the magic bullet here. If you want to look for more, we published our book, which is in the POCUS book, and that's provides a lot more on the POCUS and the NP training, both cardiac and non-cardiac. Is a very comprehensive textbook. And also there's a lot of information on the neoecosim.com. That's our website for the echo simulator. I'll stop it there, and I'll be happy to take any questions.
Thank you, Best thing. That was fantastic. I loved how how those cases illustrated how POCUS adds so much real-time physiological information to deal with those emergencies. But I'm going to pass you on to our moderators. You can see we've got a couple of questions in the Q&A. We've got Dr. Jean Yong, who's a consultant from London, who's part of the NeoFOCUS education team and a passionate advocate of neonatal POCUS in the clinical setting. And of course, we've got Dr. Mahmood Montassa, who is the chair of the NeoFOCUS group, who are moderating and will look at the questions and pose some questions to Professor Singh. But thank you once again.
Thank you, Liam.
Thanks, Liam, and thank you again for this fantastic talk. As always, brilliant and very insightful. We've got a few questions on the Q&A. There is one about the use of safer versus the crashing neonatal protocol in case of mild pneumothorax. Are there mild trim all around or no lung point? Would that be still the case?
So first thing, that's a great question, really. So, and we use this one to look on the size of the pneumothorax, whether we should intervene now or not. First of all, tension pneumothorax is a clinical diagnosis. You'll see clinically. So that's the first thing. The baby detect the pneumothorax and baby is stable, then you can start looking how big is the pneumothorax. So you start from the midpoint where we started initially in the question in front, then you can go laterally. If you can find a lung point and if you can the anterior or mid-axillary line, there's a clearly you can see demarcation between the lung sliding, no lung sliding, and the V-line scum, then you know this baby has got a larger or small pneumothorax. Limitation of the ultrasound is you cannot tell about how lungs are expanded. We cannot quantify the volume of the air because air cannot be detected by ultrasound. But it can help in finding it's a smaller pneumothorax or it's a larger tension pneumothorax. But baby is decompensated, just put the needle in. In that case, there is all that with the clinical. Ultrasound, POCUS, CNP, or safer use pneumothorax in or out, then look on the baby and decide from there. Baby is stable, then you can teach and train other animals as well, lung point, everything. So then you can decide is it small or large.
Great, thank you.
Thank you. Thank you, Yogen. So the had a question about probes in the chat. So you mentioned that a single probe can be used for the SAFER protocol. What type of probe do you recommend? And are there any handheld probes that you're aware of?
Yeah, that's a great question, Jean. I think again, people may differ on this answer. So in the SAFER protocol, like previously, and many people in the many NICUs I know around the world previously, like 10 years back, 5 years back, they had only one probe, usually for the ultrasound head, really microconvex probe, and people use convex, and that's what a lot of adults use as well. Personally, I use 12S or the cardiac probe because I know most babies cardiac probe can provide other imaging as well. You got the microconvex, you got the frequency around 8 megahertz. If you use a frequency around 12 or 6 to 12 megahertz cardiac probe, that can cardiac, non-cardiac, everything. So personally, I use cardiac, smaller probe available. But in emergency, doesn't matter what probe you have got, all will do the job. Here is not looking for the best quality pictures or the best imaging. You are looking for the very obvious causes. So even people use the linear probe for this one can be used. So I will not fix on the one probe. What is available, use, but there's one probe. In that case, I will still go for the cardiac because we may miss things there. First thing. Secondly, is do not change the probes in between rapid assessment. What a probe you use, just use. Once baby is stable, then use the cardiac probe for the cardiac indications, linear probe for the lungs and vascular, those things, and then you can use like whatever we teach normally.
Thanks, Yogen. There is another question about the, obviously we've got the SAFER protocol, we've got also the crashing infant protocol. The question is, have you thought about merging both together in one protocol? Because I know one start with one entry point, the other one starts from a different entry point. And the other question, have you thought also about validating that?
Those are, again, the questions are really good. I like the questions. I think the no point of merging, both have their own roles. Just like in the adults, there's certain many protocols are there. We cannot use one. If you've got a baby who is really crashing and people don't go on the whole stepwise, like a CNP is a little more lengthier, looking on the abdomen and needs to do more features on those sides. If you're using only for like, okay, I just need to vary 5 important things, go for the safer. If you are trained and you've got a little more time and you want to look on the NEC, go more details, you can see, and people have got their own role. They do the similar things, but it's slightly different for a reason. And the lastly question is about the validating. This is where I need your help, audience help, because that's where we did the protocols and we use. For me, for some of us, it will be very hard, like say, if you're, shall I randomize? Randomize is not the option for people who are already studying use. So I think there's one study that came here from Ibarra group really, and the Ibarra group. They modified the safer protocol and they implemented. They saw using 25 babies, they could in 5 babies detected the abnormality early and they could intervene. So they work. We know that. Question of validation is where we need to join hands, like say NeoFOCUS tomorrow, if we all join hands, because these babies are rare. They do not happen around the clock. And they happen often in the middle of the night when we are not there. Like you're not there 24/7. So we need to join more and more centers. If you've got 1 or 2 cases from each center, you've got 50, 100 cases, that's the only way we can validate it. Otherwise, it's hard.
Absolutely agree. And I think it would be a really good project to join hands together, maybe build like a database international and just put on those cases into that database. That would be really good.
Absolutely. I think that would be a fantastic initiative. And I do have a couple of cases for you actually, if you would like that. So we have another question in the chat about your advice on how to implement SAFAR on a neonatal unit. Myself and others use it on UK neonatal units, but how would you go about implementing it in the best way in your experience?
The key point is really train the people, because what you need really, people who are on the floor, people who are the first line providers, like in the UK, whether we are got the specialty registrars, because often they will be on the forefront of the nurse practitioners. In the US, the fellows and nurse practitioners. If you got a 24/7, if you want to really implement a unit, you can use when you are there, but that's not going to impact will be less impactful. There'll be less outcomes will not improve if 1 or 2 people adopt it. If the whole unit approach, you train maximum people in the minimum ultrasound use. That's what saying Jane was saying. Adults, what they did, they went into very limited indications and used the POCUS, trained everybody in that one. If you go to the emergency A&E or ER today, so they will use only like even the B mode. They don't go even the color mode, but they use so repeatedly, everybody knows what they're looking for. So that's what we need to do. We need to train our maximum colleagues, especially the consultants, especially the attendings. We in the US, attendings, consultants in UK, the same thing. So we are the probably more laggards, I have to say, because nurse practitioners and fellows, registrars are more keen to learn. Attendings are a little slower. So we all need to lead by example. We train ourselves for at least for the emergencies, use the POCUS, and the guideline is the implementation is very easy because it's very simple to use. Machines are there. Just we need to train people, and people need to say, "Oh, I can use." And honestly, once you train, people use more than what you think. I can tell many occasions in my unit like I moved to UC Davis recently, like about a year back, but we have been really working hard to train our colleagues. And the same situations everywhere. We nurse practitioner fellows come forward first, and our colleagues then get along as well, and they train as well. And it's acceptance is by the team. Like our team accepted, that's why we are here. Team want to build this program, and my attending colleagues, they have full support. Now what we do, like what we have done, even like 2 days back, baby's crashing. First thing they come, even this assessing the baby is crashing, it's not coding situations, just compressions. Let's get the ultrasound machine. Let's look on the pneumothorax, let's the tamponade. And that's where it will be implemented. Then somebody said, oh, X-ray is here. So that's where you need to just train people. They need to baby crashing rather than spending time just blindly looking on the interventions. They need to adopt this one in the practice. But training maximum people is the key.
Perfect. Thank you, Yogen. And just to emphasize your point, I think training and raising awareness about this is really important. That's why we have this webinar today, and we run courses across the country, couple of courses per year, and it would be our pleasure to invite you to one of those next time, because I think raising awareness and training is the key. So hopefully more people will adopt that protocol.
Thank you.
So there is another question about pericardial effusion. If you successfully drain the effusion after identifying a malpositioned line, would you adjust the line and keep it there, or would you just remove it?
That's a difficult one. So probably if you got I will remove it if there is any excess before. If it has no excess, pull it lower. And if you have to give the epinephrine, adrenaline, part of the rhesus coding, if there's no excess left, that's not a good solution. But if your line is too far in, definitely, if you got a other excess, remove it. I think that's the easier one to get is other line, but you don't know where the problem is. This line is problematic already. I will remove it, and in all cases, I always removed it. I know this question has been asked before, where they say we have no lines. I will remove it, and even in the really coding situations, in that case, you can pull it down, use for emergency use. But if it doesn't work, use alternatives as well. This line may not be in the veins already there. So I think it's a tricky one. But remove it as soon as you can and use alternative in the main.
Yeah, absolutely. We don't know what's happening with that line, so I think it's safer to remove it. Absolutely. Thanks.
Thanks. And a further question in the chat about how far should we implement POCUS training in neonatal training for resident doctors? How much should it be a mandatory skill, and how much should it be part of routine examinations?
Again, that's a great question. I think how far are we? It really depends where you are. So it depends on the unit. I know the countries, I know the units where ultrasound, they mix really like say POCUS and TNE and NP because they're both trained. They use in almost everywhere we hardly use X-rays. I know the units. Equally, I know the units where they're not being used a lot. So it really depends on the expertise. I think we're coming quite far. Like I think US was probably we're a little more behind in adopting POCUS until a few years back, but now we got the National Neonatal POCUS Collaborative, and most people from the most hospital people are joined in hands, and I can see there's a lot of movements here, and most people are now adopted POCUS program. They say in the US news came really last year that said every tertiary like the bigger unit, they should have the POCUS program. So like this coming our way. So it's not there yet. Every unit does not have across the world, but it has been, is widely and fast being adopted. Biggest challenge is, as we said, really is the awareness and more importantly, training, because it does take time. If you want to train people, we do not want the sloppy training. We want to keep the training high standards. Well, it's a POCUS. Again, it's not like you go 2-day course and you're done and dusted. No, we want them to do a course, then do the supervised training. What are the numbers of ultrasounds can we arrange? Again, that's still early days. Hopefully, in next few months, you will see, at least for the lung ultrasound, we'll have some international consensus on the training, how we can train lung ultrasound, how we can certify people. Cardiac POCUS, we said 75 in the North America. Again, those are the training that are coming. So training is the key there about the implementation. Otherwise, a lot of movements are there. In the coming days, I think, coming years, it takes some time. This is very recent. If you look on the surfactant use, look on the many practice chain, they took a long time to come to practice. But ultrasound in 5-10 years, we have made practice very fast progress. So it will come.
Thank you.
Fantastic.
And
Thank you.
just to on that note, we're doing a lot of work here in the UK with our group and collaborating with BABM as well, and hopefully we'll produce soon some guidance and frameworks about that as well.
That would be really great, Mahmood. I know. I think NeoFOCUS is doing great job, and honestly, UK has been forefront with the functional echo training, what we used to call initially with the NP, and same with the PACS. And because of the PACS is such a resourceful, because that easier was for us to go into the neonatology from the cardiology side. So you are in a very good position, and it's a long awaited with the BAPM. I'm really glad last time as we were chatting, you and I were chatting with somebody else as well. So that one is really great news, and I think a good step forward. And I think that's a good set an example. That'd be really good. Let me know if I can help you with anything with that one.
Thank you. Any more questions?
Thank you, Yogen. I think
There was just one more in the Q&A. Just
I can see one more question. Can you use electrocardiometry instead of cardiac focus for the hemodynamics? Again, I will say probably I don't have experience. I'm saying this intensely because I don't think most of us will have experience, especially for the emergency use. Cardiometry is pretty, electrocardiometry is non-specific. It will not help. You want to be really specific at this point. There's no point fluffing around in these sick patients. You want a yes or no. And when there's an excellent tool is there, really excellent tool, cannot be better when adults use children. Why we try to keep on looking at the alternatives? Let's adopt one simple tool first. If that doesn't work, look at the alternatives. This tool is excellent, I can say. So I think, I don't think electrocardiometry is the alternative to cardiac focus. And secondly, we're using the word hemodynamics. Again, detailed hemodynamics beyond focus. Focus is for mostly for the indications which I showed, we published the guidelines. Using the hemodynamics evaluation, then you need NP, TN echo, TNE, what are on that route. And those are where you can use additional tools, electrocardiometry as well, not a problem. Good research tool, good in the control situations, but not for the emergency, those situations where what you need, urgent echo, urgent focus, limited echo. What do you use? We are using that tool with our abilities, expertise, and for the best for the patient.
Thank you, Yogen. You had some really fantastic cases there showing the early recognition of signs, targeted treatment for the right patient at the right time. And it's such a valuable tool. So thank you so much for sharing your knowledge with us. I think those are the end of the questions. I'll let you wrap things up, Liam.
thanks, Jean.
It's my pleasure, Jean. Yes, my pleasure, Jean. Thanks for inviting. That's why we are here. As Mahmood said, we are spreading the knowledge, spreading the awareness, and that's where we are. And I think we say it's not a one-person job. NeoFOCUS doing a great job on the UK side, European side, the same on our collaborator on this side. Espenic is definitely doing a lot on this side. But again, we all do in our own time. So we are not obviously paid for any of this when we do voluntary basis. We have limitations, but we all are working hard to bring this to the practice. So it's a very bigger team collaborative internationally.
Thanks, Yogen, for your time. Appreciate that.
Thank you again, Professor Singh, for coming and presenting to us today. Just to say to everyone, if you could leave some feedback, that would be amazing. And with that, we'll send you a certificate which is embedded in your registration when you registered for this webinar. And just a further plug for the work that we're trying to do in the NeoFOCUS group, that in the chat, so I've just left a link to the upcoming course on the 9th and 10th of October. if you want to register for that course, looking at hemodynamics and getting a hands-on course with echocardiographic views as well. So just a bit of a plug there for that. But once again, I think we should all thank Yogen for his fantastic presentation today, and we'll send out the links via the WhatsApp group for the next presentation in the next couple of weeks. So thanks everyone, and have a great Friday and a weekend. And
thank you for watching. If you enjoyed this, please check out the other webinars on our channel.